Well, thank you very much indeed for that introduction. It's a real privilege for me to be here. As you've heard, my background is as a baby doctor, working at UCL here in the centre of London. And for many years I worked as a specialist and consultant in a big intensive care unit for premature babies. So it's a real privilege for me to be here. I've spent my professional life fighting for the right of life at both ends of the spectrum, particularly for premature babies and for the weakest in our society. And over the years I've cared for many babies going right down to the limits of viability. And as we'll hear, that goes out of the normal 40 weeks of the pregnancy. It's now possible for babies to survive at around 22 weeks gestation, or just over halfway, astonishingly. And over the years I've cared for many babies around 22, 23 and 24 weeks, weighing literally 500 grams, fitting into the palm of my hand. And we devote a lot of care and attention to caring for some of these tiny little babies. That's actually my hand and one of the babies on the baby unit, just to give you an idea of scales. And the extraordinary thing is that this has been a very rapidly and dramatically improving area of medical technology. And we, as a society, devote enormous resources, very significant resources, into ensuring that babies will survive. The sort of NHS cost of providing care for one severely ill baby, an extremely premature baby, is up to £2,000 per baby per day. So the total costs of ensuring that an extremely premature baby survive can literally be £100,000 or more. And thank God for the NHS, because that is all paid for by the state, free at the point of need, and completely irrespective of the background of the parents and so on. So this is an extraordinary sort of looking glass world in which we live, that on the one hand we're investing a huge amount of resources to ensure the survival of very premature babies, and yet at the same time, as we've heard and we'll hear some more, there is this whole industry which is dedicated to destroying the lives of unborn babies. And in a modern NHS hospital, these two worlds collide in a very strange and troubling way, because literally one floor away from the neonatal intensive care unit, where I spent most of my life working, is the fetal medicine unit. And here, pregnant women from a wide area of London and the southeast of England are referred if an abnormality of the baby, the unborn baby, the fetus, is diagnosed. And again, sophisticated technology is employed, with the idea being to try and identify if there is an abnormality, and that includes things like ultrasound, we'll see some images, but also fetal MRI is now being used increasingly. And if an abnormality, a significant abnormality of the baby is found, then the mother will always be offered the option of an abortion. And because of the extraordinary way in which the law works, current law works in the UK, it's legal for an abortion to be carried out for medical reasons at any stage of the pregnancy, all the way up until term. And so many times in my career, I have been called up from one floor where we've been struggling to save premature babies, to go and talk to a mother who has discovered that there's some abnormality of her fetus and is being offered the option of an abortion. And she has asked to speak to a paediatrician, or it's been advised that she should speak to a paediatrician, and I have gone to speak to her about what the implications would be for her baby. And the baby in her womb is considerably bigger and tougher and stronger than many of the babies we're struggling to save one floor down. And in my own hospital, late feticides are carried out sometimes at 26 weeks, 28 weeks, 30 weeks, 32 weeks, even beyond. And you say to yourself, how is it possible in one hospital for these two contradictory activities to be going on. But that is a phenomenon of the modern world, and it's something I recognise increasingly, that it's perfectly possible for people to believe two completely contradictory things and not to notice. And from a Christian point of view, if we're Christian believers, I think we can see this as an example of the way that people's minds are clouded and masked by the activity of the evil one, and that inability to join the dots, to see the connections. It's something I think we see repeatedly. So the abortion statistics, we've already heard the headlines of these figures, but they're really chilling numbers just to see what there are. The total number of abortions, as we heard, was 205,000. That's the highest number there's been ever since the Abortion Act came in. 39% of abortions were in women who've had previous abortions. 98% are funded by the NHS, even though 70% actually take place in private clinics. So the pro-abortion groups have worked out very hard to try to remove any kind of barrier to make it as easy as possible for women to receive an abortion. And so now it's not necessary to go through a GP or through a hospital or a clinic in any way. You can simply ring a hotline, go straight to the abortion clinic, and you can have the abortion the same day, and it will be funded by the NHS. All you have to do is give your postcode, and the NHS will collect the tab. And this is a real issue because it's a real issue for the crisis pregnancy centres, because just to have a chance to help people to think about the option when so much of this is now done in private clinics. Again, this is intentional because the NHS wants to get abortion out of the District General Hospital because of the complications and difficulties and trauma it causes for everybody. The more we can outsource this into a specialised abortion clinic, that's really very much the plan. There's been an increase in the number of medical abortions. I'll come back to describing just briefly the difference between medical and surgical abortions, but 71% are now medical abortions, and 1,800, over 1,800 were performed at 22 weeks or more. So although the majority of abortions are carried out early on in pregnancy, in the first 10 weeks, there is still very significant numbers taking place beyond 22 weeks and over 280 beyond 24 weeks. The vast majority, as we all know, are carried out for so-called social reasons, and the numbers that are carried out because of a fetal abnormality, which is the particular kind I as a doctor get involved with, are actually about less than 2%. That figure is slowly climbing up as more and more sophisticated fetal scanning is being undertaken, and therefore more and more abnormalities are being found. And this is something I'm deeply concerned about the future, because in the future it will be possible to get a complete genome rating from an unborn baby. That's already technically possible, and I think this is about to be something that's going to become commercially available. And what that means, therefore, is that potentially an unborn mother will be able to be given information such as the chances that her baby's going to get breast cancer, or the chances that the baby's going to develop a dementia, or all kinds of genetic conditions. And then he's going to be asked, now, do you think it would be responsible to bring this baby into the world? And you can just imagine how just ordinary people who've never thought about this are suddenly going to be confronted with terrible dilemmas. In fact, a whole number of occasions when, for instance, again, this is happening later on in pregnancy. So, for instance, a woman, for whatever reason, at late pregnancy, goes to see a doctor. They say, we're just going to do a scan. They do a scan of the baby, and it shows something abnormal about the brain. You get a fetal MRI, and then say it could be at 32 weeks. And the mother is, hugely pregnant, baby's kicking and all the rest, and then the doctor will say, well, we are worried about the brain development, and it could mean, we're not certain, but it could mean your child is going to have some anyway. Now, do you think the right thing, it would be legal to do an abortion, even at this late stage, do you think the right thing to do would be to bring, and often that word is responsible, would it be responsible for you to bring this baby into the world? And, a number of women have said to me, doctor, it would be much better if you hadn't told me. If I didn't know anything, I would have just carried on, we would have cared for the baby, whatever happened. But now you've put me in an impossible position, because either I am responsible to agree for my baby to be killed, or I am responsible for bringing into the world a potentially severely disabled child. And what kind of option is that to present a parent with? So these are very troubling and difficult issues. Finally, just to point out that the number of abortions that are done because of a risk to the mother's life, these are the so-called hard cases that are often referred to in debates and polemics. It's actually exceedingly unusual for abortions to be carried out because there is a genuine risk to the mother's life. It's nearly always possible to save both the mother and the baby. And my experience is that when there is a severe illness and a threat to the mother's life, the natural instinct of a mother is to do everything possible to try and risk her own life in order to save the life of a baby. But I think as we just look at those statistics, I'm reminded of this verse, which seems to be one of the bleakest verses in the entire scriptures. A voice is heard in Ramah, lamentation and bitter weeping. Rachel is weeping for her children. She refuses to be comforted for her children because they are no more. And this terrible, terrible grief that so many dead babies, and it's carrying on. If anything, it's getting worse. And I'm afraid just some grisly information. So forgive me for having to say some of this medical information, but surgical abortions. There are two different ways in which surgical abortions are carried out. It can be a vacuum aspiration, just literally with a suction catheter, and that can be carried out up to about 15 weeks. And this can be carried out either under a local or a general anaesthetic. And beyond 15 weeks, this terribly gruesome and horrific procedure is carried out, which is called dilatation and evacuation. And this is carried out under general anaesthetic, but then the operator, the doctor, opens the cervix a small amount, and then literally putting in surgical instruments into the womb, dismembers the unborn baby, and literally limb by limb, bit by bit, the head is often crushed and the whole thing is just the bits are coming out. And I'm afraid this is carried out on a regular basis in abortion clinics. And as we'll see later on, there are real concerns that the fetus may well at the later stages be capable of experiencing pain, and no attempt is made to ensure that the fetus is even anaesthetised in this procedure. And so this is the gruesome reality of what's actually happening in abortion, and this is legal for that to be carried up to 23 weeks and 6 days, that process of dilatation and evacuation. The other approach to abortion is the medical abortion, and here it's a combination of two drugs are used. The first drug is called mifepristone, and that acts actually on the lining of the womb and opposes the action of the normal hormone progesterone, which is protecting the fetus. And so it usually leads to a breakdown of the lining of the womb, and usually at that point, but not always, the embryo or fetus dies. And then after a period of 24 to 48 hours, a second drug, misoprostol, is given, and this causes the womb to contract very forcefully. It can be extremely painful, I understand, and very distressing, not just physically, but of course emotionally as well. And the womb contracts, and that for them forces out embryo or the fetus. And this is currently by the regulations, the first dose has to be given in a licensed premise, so it's normally given in the abortion clinic. But then what will happen is when the drugs have been given, the woman will go home and then will often pass the embryo or the fetus into the toilet. And one of the tragic things about this is the psychological consequences. At least when abortions are carried out in an abortion clinic, at least there are trained professionals present and some kind of support can be provided. But the reality of medical abortion taking place at home, I'm afraid, can be utterly horrific, particularly at the more mature stages when actually the fetus can be alive and could be passed into a toilet bowl. There could be people deeply distressed, bleeding, and there may be absolutely nobody there. But a woman could be completely isolated, unsupported. So the contrast between the rhetoric about, the wonderful thing of woman's choice and how wonderful it is, and the actual reality of what's taking place in the bathroom is to me very stark and chilling, really. And just to divert for a little thing, from a medical perspective, I think that one of the things that most people, including legislators, are not aware of, but that is that calculating gestational age is not by any means an accurate activity. In fact, the only way you can accurately know what the gestational age is by having an early ultrasound scan. And even an early ultrasound scan has margins of error of up to 2 weeks. So even with accurate dating, it's possible that a baby who is said to be 20 weeks is in fact 22 weeks, or a baby who is said to be 24 weeks is in fact 26 weeks, and so on. But if you don't have an ultrasound scan, then gestational age can be out by many weeks. And I have seen cases where a woman thought she was 12 weeks pregnant, and in fact she was 24 weeks pregnant. And that's, because a lot of women have irregular periods. Sometimes the last menstrual period date is forgotten or it's got wrong, or it may have been what's called a false period. And so the impact of decriminalisation, at the moment, every time a woman goes to have an abortion, the first thing they do is an ultrasound scan in order to date the pregnancy. To me, the nightmare scenario is that if there was decriminalisation, it would be perfectly possible for a woman to get abortion drugs over the internet or from a friend or at a club. She could go into her home believing she was in early pregnancy, take the abortion drugs and pass, and go into labour with a really developed fetus, completely unsupported, at home. The baby may be born alive. Again, no support, no care. I mean, it just, again, seems to me almost barbaric that this is what's being proposed, and it's all in the name of feminism. It's the woman's right to her body, and so on. At current, abortion beyond 22 weeks, the Royal College of Gynecologists has said that a procedure must be done that will kill the fetus, take the life of the fetus, before delivery. And the technique that is commonly used is, under ultrasound guidance, the fetal heart is visualized, and the woman is just given a local anesthetic, and then a needle is inserted through the abdomen directly into the heart, and a lethal injection is given directly into the heart. And it's ensured that the baby is dead, and then the woman is given the drugs which will then start labour, so that then 24 or 48 hours later she will go through the whole process of labour and will then produce a dead baby. Sometimes the medication is injected into the amniotic fluid, and in that case death doesn't occur instantaneously. It may take several hours. And again, there were over 1,800 abortions beyond 22 weeks last year. There is a screening program which is again dedicated to try and identify abnormalities of the fetus, and there's a sort of whole industry which is devoted to trying to identify abnormalities before birth. So I'm sorry to have to give these painful and grisly details, but this is the truth of what's going on. Just now to move to some details about the whole process of baby development in the womb. So the process of fertilization takes place actually in the tube, the fallopian tube. So each month the mother produces an egg, the egg is released and starts to pass down the fallopian tube. And if sperm is present and it migrates up the tube, the sperm meets the egg actually in the fallopian tube, and fertilization takes place. And it's at that point that a new individual starts. The DNA from the father and the DNA from the mother are then fused, and a new individual, a new genetic code starts at that point. Then what happens is that the fertilized egg passes down the tube, and there's actively movements of the tube in order to waft the egg down the tube, and eventually it passes through into the womb and then burrows into the lining of the womb. And that's the process called implantation. So by this time there's a ball of cells, and the cells are now, the embryo is now burrowing into the lining of the womb. And that normally takes place at about 9 days or there, give or take, from fertilization. And from that time on, the embryo rapidly develops, and at around 18 to 19 days after fertilization, the heart begins to form. And the heart's the first functional organ to develop, and it starts to beat and pump blood at around 21 days after fertilization. And you can see the heart beating here, and well, you can't see it beating, but you can see where it is. And the brain and the spine are also starting to be formed at this stage. And the embryo is about 5 millimeters in length, and it can be seen remarkably from this time onwards. It can actually be seen by modern ultrasound, so you can pick up and show that the embryo is alive and present there. This is at 6 weeks post-fertilization, and by this time the embryo is about 1 centimeter long, and the hands, the feet, the mouth, the face, they're all present. And in fact, you can start to show movements from about this stage. Now, there's just a technical complication here, and that is gestational age is actually measured from the last menstrual period. And that's not the same as the time from fertilization. Fertilization normally happens 2 weeks, give or take, after the last menstrual period. So at this point, the embryo is 6 weeks post-fertilization, but is actually 8 weeks gestational age. And so from now on, I'm going to talk about gestational age, because that's what the legislation talks about. That's the normal way in which we refer to. So you just remember that the date from fertilization is actually 2 weeks less than the gestational age. And technically, you're an embryo up to 8 weeks gestational age, and after 8 weeks gestational age, you're a fetus. And the reason for that distinction is that in the embryo, the organs are in the process of being formed. Once you change from an embryo to a fetus, all the organs are there, and it's now mainly a process of growth. But because now the basic structure of the body is complete. So by 10 weeks gestational age, the fetus now can be observed to be yawning and stretching and moving. There are sensory receptors all over the body, And there are nerve connections going from the skin to the spinal cord. And this is a baby at 12 weeks gestational age. But remarkably now, with improvements in ultrasound, we can actually see the baby. And so this is at 12 weeks. And if you watch, you can see that the baby's already moving around and is very recognizably a baby. And these movements become more and more obvious as time goes by. So that's at 12 weeks. And by this stage, the baby is sucking and swallowing. Shows what's called rooting behavior. It can find the thumb and or a hand or a foot or some other body part. And from 14 weeks, the skilled ultrasound practitioners say they can actually recognize facial expressions. They can see things, movements of the mouth and the face. And then this is at 16 weeks gestation. Again, now you can see all the details of the hands and the body as a whole. This is what a 16-week scan looks like. You can see that the baby's a lot more active now and moving around. And it's interesting that at this stage, although the baby is very active, usually the mother is completely unaware of the fetal movements. It's not until later on that the so-called quickening happens. Previously, philosophers and theologians and other people put a lot of emphasis on the quickening, but we now realize it's simply a question of the size of the baby. The baby's actually very active from long before the quickening. It's just it's when the baby reaches to a certain size that you're able to feel, the mother's able to feel it. By this stage, the development of the lining surface of the brain is now progressing, and nerve connections from the body are coming through to the brain and starting to make connections throughout the brain. This is at 20 weeks, and now at 20 weeks, as technology has advanced, it's possible to do MRI. And this is an MRI of a baby at 20 weeks. It's extraordinary. So, more and more, as we understand fetal development, we realize that the fetus is not just a sort of passive occupant inside the mother's body, but actually is very actively involved, engaging with its environment and responding to sensation and so on. And yet the extraordinary thing is, even though this science is very well known and recognized, the RCOG, in their information for women who are considering having an abortion, say that the fetus is deeply asleep and unaware throughout the pregnancy. There's a sort of, again, an extraordinary mismatch between the rhetoric that is being used compared to what the science shows. From before this stage, you can also show, sometimes now we do medical procedures where on fetuses, and it's been shown that the fetus responds behaviorally if you stick a needle into the fetus, not surprisingly, and also you get release of stress hormones at this gestational age. So by the time you get to 22 weeks, we now have a significant number of babies who are now surviving, and some of whom I've cared for myself within an intensive care unit. And yet, remember that the legal limit is still 24 weeks at the moment. So this baby could be legally aborted for no reason at all under the law. That's a 23-week gestation baby as well. And the ultrasound continues to improve. By the time you get to 26 weeks and beyond, you can get remarkable detail of the baby inside the womb. But one of the extraordinary things that happens in the ultrasound department is that the first thing the person who's doing the ultrasound needs to know, an antenatal ultrasound, is this a wanted baby or not? If it's a wanted baby, the screen is turned to the mother, and all the language is about, oh, look, he's waving his hands, oh, yeah, he's got his same nose as his daddy. It's all this sort of friendly baby talk. But if the baby is not wanted, the screen is turned away from the parents, and the language is completely different. And they say something like, well, the pregnancy seems to be developing normally. And it's this sort of very anodyne and sanitized language. And yet, the being in the womb is exactly the same. And it's almost like the value of this baby depends on whether it's wanted. And that is the fundamental outrage, in a sense, of what is currently happening. So I often use this slide when lecturing medical students on these kind of issues and say, this is what you look like when you were born. This is what you look like at 28 weeks. This is what you look like at 18 weeks. This is what you look like at 6 weeks. This is what you look like at 3 weeks. This is what you look like at 3 days. And as we trace back our own personal history, is there any point at which you can say, that is not me? And I think the point is, it is. And even when, you look like that, our Heavenly Father saw you and knew you and loved you and was calling you into existence. And so the wonder of what modern science and ultrasound is giving us is allowing us to see what God is doing in what used to be previously the hidden place. And I like this slide I found on the internet, where this is a very early ultrasound, and this is a tiny little piece of tissue which is 5 millimeters long. But what love sees is a baby. We're having a baby. And that's the point. As we reach out to this being, what we see is not just a piece of tissue. We see a baby. And that's beautifully expressed by Elaine Storkey, who wrote these words: pregnancy itself is itself a symbol of deepest hospitality. It's the giving of one's body to the life of another. It's sharing of all that we have, our cell structure, our bloodstream, our food, our oxygen. It is saying welcome with every breath and every heartbeat. And for many mothers, that welcome is given, irrespective of the demands made on one's own comfort, health, or ease of life. For the demands of this hospitality are greater than almost any of our own. And the growing fetus is made to know that here is love, here are warm lodgings, here is the place of safety. In hiding and in quiet, the miraculous growth can take place. But then, for Christian believers, the story is even more bizarre and more wonderful, because God himself has invaded the womb. And he himself has become a fetus. And I think we're so familiar with the Christmas story that we've actually forgotten how incredibly scandalous and bizarre it is that the God of the universe, the God of total power and authority, should turn himself into a tiny, pathetic, defenseless fetus. And so there's a beautiful sense in which God, in the person of Jesus, has experienced every phase of human existence. He was with us in the darkness of the womb, as he will be with us in the darkness of the tomb. There's nothing that we can go through which, in some sense, God himself hasn't experienced in his own body. He has in his own nature. And there's this wonderful passage in the first chapter of Luke, where you remember Mary has just received the visitation from the angel, and she takes a deep breath and she says, I am the bondslave of the Lord. Let it be to me as you have said. In other words, I say yes, I give my consent, I give my agreement. And then she goes running to see her cousin Elizabeth, who's also pregnant. And as she comes running into the place where Elizabeth is, no doubt calling her name with this wonderful news, Elizabeth is filled by the Holy Spirit, and she says, "Blessed are you, Mary, and blessed is the fruit of your womb. And why am I so favoured that the mother of my Lord, should come to me? As soon as the sound of your greeting reached my ears, the baby in my womb leapt for joy." And I think you can just very approximately work out where these two fetuses are. So this is John the Baptist. He's about 28 weeks, and he's leaping for joy. So where is Jesus? Well, probably he's about here. In other words, he's no more than 2 or 3 millimeters. And yet, Elizabeth, filled with the Holy Spirit, says, "The mother of my Lord." So there is something utterly profound about the development of the human being, because God himself has been there. And I therefore believe, in a sense, that because God became a fetus, then every fetus is special. Because God became a baby, every baby is special. Because God was a dying person, every dying person is special. And so, just from a spiritual point of view, when I think of that, when I look at this slide, and I say to myself, where is God in this picture? And where are you? Is God the great big hand, and you're the tiny little hand clinging on? Well, yes, that's very often how we feel. But actually, you can turn the picture around and say the God of total power and authority chooses to turn himself into the little hand. He chooses to make himself vulnerable and dependent. So I've run out of time, but just very briefly, to go back from that exalted theology to the neuroscience, this is how the pain develops in the womb. I haven't time to describe it in detail. There is a book going to come out later on, which is going to have much more detail about the evidence about the fetus being able to suffer pain and so on. This is an extraordinary photograph. This is a surgery being undertaken on a pregnant woman with a baby who has spina bifida. And this is a surgeon's finger, and this is the hand of the unborn baby. So the extraordinary thing is that in fetal surgery, this is the patient. This is the one for whom everything is being devoted to try to treat the baby in the womb. And again, it's this extraordinary mismatch between the approach in abortion and the approach in fetal surgery. So I'm just going to fast forward through the statistics and just close with the privilege of caring for some of the very small, tiny babies that I've had over the years, including some who've died. Even babies with congenital malformations, with lethal abnormalities. Each one is special, each one is precious, and I believe that in other words, whenever we say that abortion is wrong, we've immediately got to go on and say, and here is a better way. Here is a way to celebrate life. Here is a way to do the best for the vulnerable human beings in our midst. And while I was working as a paediatrician, at UCL, we started a bereavement service for all the parents who'd lost babies, and including those who'd had stillbirths and others. And each card represents a baby who died, and at this simple service, we brought the cards to the front, and they were dedicated to God, that each life was precious, each life was significant. And I close with these words from Joseph Piper, the philosopher, who said, "Love is a way of saying to a person, it's good that you exist. It's good that you're in the world." The trouble with abortion is it says exactly the opposite. It says it's bad you exist. It would be much better for the world if you didn't exist. But love always says it's good that you exist. It's good that you're in the world. Thanks so much.